Good afternoon. Thank you very much to the audience here assembled and also our web people watching us from their various locations. Mireille and I are very pleased to be here today to share with you our reflections and insights from our project as part of the collaborative with CFHI. And our project is to look at experience-based co-design to improve care processes for newly diagnosed children and youth with cancer. Yes, good, got it right. So I'd like to start by giving you just a little bit of context. The Children's Hospital of Eastern Ontario, or CHEO as we refer to it as, is an academic pediatric health centre providing care for children and youth from 0 to 18. You can read the stats to give you a sense of our scale and scope. And CHEO has the distinction of being the largest running patient and family advisory forum that we know of. We're about to celebrate our 25th anniversary in existence in our facility. And with our robust level of involvement, Family Forum was looking at best practices for patient and family engagement. And we're really interested in looking at what was happening with experience-based co-design. So when this project was conceived and when the call for proposals and funding, we really wanted to move forward with this work and explore it. And we started with oncology, mostly because there were some projects already underway in terms of some lean process improvement, but also because there is some significant family involvement of patients, the youth, and also families with oncology diagnosis. So I'm just going to turn it over to Mireille, and she's going to go through some of the processes that we went through.
Great, and I'll actually go through the experience-based co-design process really quickly, because there are some really great tools online. The King's Fund website provides an experience-based co-design toolkit. When I started my work at CHEO, it was actually very easy because everything was at my fingertips. With supporting documentation, supporting research, and even presentations, agendas, etc. So I encourage you to learn more about experience-based co-design by going to that website. So in terms of our specific experience, I'm going to, yes. So when I started, there were two primary aims, and my mandate was to test the effectiveness of experience-based co-design as a way of involving patients and families in quality improvement. And in so doing, you see, we crossed out that aim of improving patient and family and staff experience. It was a very generic aim because part of the EBCD process is that we identify together what it is that we want to improve. So later on in the process, we replaced that generic aim with a more specific aim to improve the oncology orientation process and support and materials to ensure oncology patients, families, and staff have the knowledge and resources to become good partners in care. That came out as a theme in the analysis of our data that we collected through EBCD, that it was critical to make sure that people from the get-go really understood what it meant to be a good partner in care on both sides. So again, our objectives were specific to the EBCD process. It started out with ethnography, identifying, tell me about what you've experienced. We did that both with groups of families. So we had 12 families that volunteered to participate in the project, and in those 12 families, all 24 parents were involved. 5 youth were involved, and 2 siblings were involved in the original interviews. Those were video interviews with patients and families. I told you that I wouldn't get into the details of the process. So all to say, fast forward. I'm not going to, don't try to read this, but all to say that the British Medical Journal, there's a very brief paper actually that came out recently in 2015 that Glenn Robert put out. And I think the British Medical Journal put out this infographic. And when I first looked at it, I thought, oh, how horrible. It looks like a little bit of an assembly line. But if you read the details, and I do encourage you to go visit it, it does give a very good synopsis of the process. My challenge when I started out the project was that what we called phase 1, that ethnography, where we listened to stories and tried to deepen our understanding of mutual experiences Again, very well supported through the King's Fund website. When I was anticipating what our improvement projects would be, I was beginning to wonder what the tools, and if you go to the King's Fund website now, it's updated. There's more around co-design. They point you in the direction of other resources. There's a good website in New Zealand that describes various co-design practices. But it forced me to look to see what was happening at CHIO. So the idea was that we would test EBCD, and then based on our lessons learned, we would then go back and see how do we incorporate this in the quality framework. But we were going to implement improvements, and it only made sense, and I was hearing it from staff. We're doing lean, and now we're doing this other thing, and we're so busy, and how is this going to work? So I thought, we better integrate earlier. So I drank the lean Kool-Aid, and it was not bad, actually. And I'm going to, I'll specifically tell you after this slide. So at one critical point, this is right before we started incorporating some of the lean practices. But I think this slide depicts a really key moment in the experience-based co-design process where we worked with people individually, in groups, and then they came together in a joint feedback session. And at that joint feedback session, we started by listening to a video of a collection of clips, hearing from families what the care journey had been like for them. I knew moving into this co-design session, this joint session, that certain staff in particular, might find it difficult to hear some of the clips. And I was warned by the researcher, actually, I was working with, maybe we want to delete some of these clips. So I thought I didn't want to make the content safer, but I was very careful to try to make the environment safe so that conversations could happen in a very productive way. So my first step was to meet with some of the staff individually. And this isn't described on the King's Fund website, but I think part of the success of experience-based co-design is to really get so we're trying to generate an understanding of feelings, but it's also as a facilitator to understand, and feel, where the potential vulnerabilities may lie and how to work with that so that we could really co-design something meaningful. At this session, what you see now is we spent the morning, we listened to the video, and then we broke for lunch, and then we came together. And what I did, the next step was to have both groups describe their improvement ideas to one another. And I started with staff, and they sat in the inner circle. Nobody volunteered to present to families. And so I said, you're going to present together through conversation. So they just bounced their ideas back and forth with one another in this inner circle. But through that, described to one another what it was like for them to work, what it felt for them to work, to go through a shift. And the group of families after we switched, where the families were going to present what improvement ideas they had. So when that switch happened, a group of very vocal families, they did not have their langue in their poche, their tongue in their pocket. It was silent, it was quiet, and one of the family members looked at the staff and said, we had no idea what it was like for you. And from that moment, the conversation happened in the afternoon where we identified what our improvement areas would be. So we came up with some priorities. They were scoped according to a lean way, an A3 thinking methodology. And we then designed co-design projects together using various lean tools. And I don't have time to get into the details of it right now. But the huge lesson for us was I tried to integrate lean thinking earlier in the process because I was anticipating we would be moving into an improvement project. But I see now that even within the first phase of exploration and deepening of understanding, there are some quality improvement tools that we could have embedded from the beginning. For example, an emotion map was created based on ABCD thinking on touch points, particular points in in the patient and family journey that were significant for them and offered clues to improvement areas. I wish I had juxtaposed that right away with a current state map so that we can identify what was happening for staff. What are the process steps around some of the touch points? So we did it later, and it generated, I think, it clarified some thinking in terms of our next steps. I think you'll get a copy of these slides. I just put together where I think the complementarity lies between experience-based co-design and lean, and how we bridge that gap. I think there's great complementarity, and I do hope to continue to work on this in the months to come. In the months to come is where we're looking at sustainability and working with our CHIO works, our lean improvement advisors, to identify ways of partnering with patients and families. So how are we going to partner?
So we have already got the 1-minute warning. So this is just from the patient and family advisor perspective, the same question the other teams in the collaborative has been given in terms of, are we a guest at the table or a true partnership? And I'm actually really pleased that a lot of the ideas that, I can read it better in English, that I put in the slide have been mentioned here today, time and time again. And again, you know, using that continuum, making it really clear what the expectations are for the family advisors, for your patients, and when you get into engagement, being ready to hear what you're going to hear back. And just I'll go to the last part, which is being really flexible, because this is not patients and families' job. They've lived it, they've come to it, usually not by choice. And you know, as your project may take on a long life, their interests may wax and wane. And then just close the loop. Be honest. We all work in organizations. We understand politics. We understand change. And I'd just like to finish with be courageous, because as we've heard today, you're taking on the commitment to hear the voice of the patient, which leads to better experience and better health outcomes for all. So thank you.